The posterior surface of the uterus, irregular uterine end of the uterosacral ligament, distal hydroureter, irregular bladder wall, adenomyosis and fibroid. So MRI is the second line management, better for visualization of the deep infiltrating endometriosis. When not diagnosis by TPS or clinical examination, MRI can be done. Laparoscopy is a gold standard. During laparoscopy, rotate the camera clockwise and anti-clockwise to examine the whole abdomen, including appendix and diaphragm. Routine cystoscopy is mandatory during laparoscopy. Advantage detection, biopsy staging can be done, simultaneous treatment can be given. Listen, peritoneum, ovarian, deep endometriosis and extrapelvic. So this is the laparoscopy finding. On left side you can see there is a normal ovary, and the right side this is the affected ovary, and left side is the normal uterus and right side the affected uterus. And peritoneal involvement you can see. So what is the peritoneal lesion? Classical gun powder, gunshot, scarring, adhesion seen, red lesion and white lesion also seen. Ovarian endometriosis, chocolate seeds, endometrioma, adherence to the blood ligament, sidewall pelvis, posterior surface of the uterus, superficially implant on ovary, subovarian adhesion. Deep infiltrating endometriosis, location, pouch of Douglas, uterosacral ligament, cervix, rectum, ureter. There can be failed on pelvic examination as tender. Nodularity can also fail. There may be adhesion and scarring. Extrapelvic endometriosis, GI tract, sigmoid appendix, superficial implant are seen. Colonoscopy done in case of symptomatic patient. Urine tract or ureter, superficial implant seen. Cystoscopy, ureteroscopy may needed in some symptomatic patient. Diaphragm and scar endometriosis also seen. Histopathologically, endometrium-like tissue containing gland stoma seen. Do not exclude endometriosis if pelvic examination, TVS, MRI or histopathology examination negative. Follow up the symptomatic patient. So, what is the differential diagnosis of endometriosis? Chronic PID, post-operative adhesion, old ectopic gestation, pelvic congestion syndrome, IBS, diverticulitis, appendicitis, and IBD. Classification, there are so many classifications: ASRM classification, NGM classification, EFI classification. All women undergoing surgery should have EFI classification completed. Women with deep endometriosis should additionally have NGM classification completed. When further fertility is concerned, patients should additionally have EFI score. Offer treatment according to the woman's symptom, presence and priority rather than the stage. This is the classification of ASRM, American Society of Reproductive Medicine. Differences between histologically diagnosed endometriosis, staging, visually diagnosed endometriosis staging. Reproductivity of ASRM is 4. Severity of pain and infertility are not correlated with the ASRM staging. Stage 1 has tremendous pain, but stage 4 is asymptomatic. This is the NGN classification: peritoneum, ovary, tube, and this part is deep endometriosis. This is the EFI score. So some key points to predict the pregnancy rate, and based on the history-related age, year of infertility, period pregnancy, surgical factor is RM score or least function score. So management depends upon the patient age, severity of the pain, extent of disease, previous surgery, patient reproductive plan, morbidity, risks after surgery, side effect of drug and cost consideration. Drug, combined first-line drug, combined conservative pill, oral progesterone, Dynogest and methoxyprogesterone acetate, LNG ISCD. Second line, GnRH agonist, GnRH antagonist and deltazole. NSAID alone or in combination with other treatment. COX. So combined oral contraceptive is the first-line drug. At least should be given 3 to 6 months. Continuous is better rather than the intermediate period. Mechanism: induce CO2 pregnancy, residualization of endometrium-like tissue. Role: reduce dysmenorrhea, dyspareunia, non-menstrual pain. Oral progesterone, first-line drug, Dynogest and methoxyprogesterone acetate. Mechanism: residualization and atrophic endometrium-like tissue, inhibit growth promotory effect of E2, high dose reduced gonadotropin secretion. reduce pain. Diagnosis better than placebo, as effective as leporide, as effective as vaseline, no change in bone marrow density, prevents recurrence, reduce pain. LNG IUCD is a first line drug. It is recommended to prescribe women a levonorgestic releasing intermittent system to reduce endometriosis associated pain. GnRH agonist is second line drug used for 3 months. Mechanism atrophy for endometrium like tissue, reduce inflammation, reduce vascularization. After omission, 6 months of pain-free period. Restrict use in adolescents as they have not maximum bone density. Patient with pain and waiting for surgery, pre-operative C-cycle of GnRH agonist can be given for deep endometriosis at therapy with estrogen progesterone. GnRH antagonist second line drug reduce pain, that is cetrorelix, elagolix, and etc. Denazole not done nowadays. Letrozole not mentioned in RCOG and ACOG. Patient with pain due to retroanal endometriosis refractory other than medical and surgical treatment, consider it with combination with oral contraceptive pill, progesterone, and GnRH agonist to reduce pain. Mifepristone is a second line drug that causes reduced pain. Drawback of the medicine cannot be used during the treatment of infertility. Recurrence rate is high. Women combined with surgery, better result. Do not use in post-operative patients who are trying for pregnancy. Cannot penetrate fibrotic tissue. Ectopic endometrium